All right, listeners, ready for a deep dive into a case that really tests those clinical reasoning skills? We're going to unravel a medical mystery, focus on how a resident tackled a tricky differential diagnosis and how their attending consultant guided their thinking. A chance to learn from both the good moves and the not-so-good moves, right?
The cool thing about this case is how it seems simple at first, but then every new bit of info throws a curveball, a classic example of why we got to stay sharp and question our assumptions in medicine. You know, always be ready for a twist.
Absolutely. So we start with a 54-year-old guy, comes in with chronic lower back pain. He's had it for what, about 2 years now, but it's been getting worse these last 6 months, even waking him up at night. Pain in his neck, too, right shoulder and sternum for the past year.
Can't forget about that fatigue and weakness in his arms and legs either, right? That hints at something more systemic going on, not your run-of-the-mill back pain.
Yeah, those are like red flags, right?
Yeah.
Make you think beyond just a simple muscle or bone problem. His history, diabetes, hypertension, GERD, and those imaging studies from a year or two back showed that multi-level degenerative stuff in the lumbar and cervical spine, typical disc bulges, stenosis, the usual suspects.
So at first glance, looks like a straightforward case of degenerative disc disease. Maybe his diabetes is making it worse.
Exactly. But here's where it gets interesting. The resident, looking at all this, came up with their initial differential diagnosis. What were they thinking?
Let's break it down.
They were considering infectious spondylotitis, thinking TB versus a pyogenic cause. He had traveled to Korea, plus the diabetes, made TB a real contender. Also thought about spondyloarthritis, maybe ankylosing spondylitis, since it was hitting multiple spinal segments. And of course, you always got to think about malignancy, right? Spinal metastasis. Can't rule that out with these kinds of symptoms.
It's good the resident was thinking about serious stuff right away, but the attending saw some gaps, pushed the resident to think bigger.
That's so key. So where did the attending see room for improvement?
Well, first off, they said, think about a wider range of infectious agents. TB was a good guess, but don't forget about those fungal infections, atypical mycobacteria, especially with the diabetes.
Thinking outside the box a little bit.
Exactly. The attending also wanted to make sure they really ruled out malignancy. Go beyond the basic tests, Make sure nothing sneaky is going on.
Being thorough, not jumping to conclusions too quickly.
Right. And they pointed out the anemia. Got to figure out what's causing that. Low iron, low transferrin saturation. Could be more than just anemia of chronic disease.
Anemia is like a clue, right? Can point to a lot of different things going on under the surface.
Absolutely. And with the axial spondyloarthritis, the attending said, use those specific diagnostic criteria. Don't just go on suspicion. Get whole spine imaging, look for skip lesions, maybe TB or signs of diffuse hyperostosis. Could be Sapo syndrome.
Great teaching points for any resident, right?
Yeah.
Specific criteria, targeted imaging.
Exactly. Now, remember, they initially thought TB, right? So they started him on the typical TB treatment with Fampin, isoniazid, pyrazinamide, ethambutol. But here's the first twist. The treatment didn't work.
Things start to get interesting.
Right. And then you get these unexpected findings on top of it. His inflammatory markers, that ESR and CRP is sky high. Positive TB skin test, CT scan of the chest, shows a few small lung nodules. But biopsies to rule out malignancy, those came back negative.
So we got signs of inflammation, a positive TB test, but no response to treatment and negative biopsies.
Confusing.
Totally. The resident had to reassess, shift the probabilities, started thinking more about Sappho syndrome, with the bone involvement, sternal pain, no response to the TB meds.
Sappho can look a lot like infection, right? All that sterile inflammation.
Spondyloarthritis was still up there, but TB less likely now. Malignancy, well, less likely, but still couldn't rule it out completely. It's like a puzzle where the pieces don't quite fit.
And that's where the attending steps in again, right? Helps refine the thinking. What were some of the key observations? The first thing was those crazy high inflammatory markers. ESR over 100, CRP of 61, way more inflammation than they thought. That alone was like, whoa, back to the drawing board.
Yeah, that's not your average inflammation.
Right. And they said, really dig into Sappho syndrome, understand those diagnostic criteria, how it overlaps with other conditions.
Not just slapping a label on it, but really understanding it.
Exactly. They talked about HLA-B-TRUM7 negative axial SPA, which this patient had, how that might affect treatment.
And those lung nodules, can't forget about those. Need to figure out what those are all about.
It's not just back pain anymore, right? It's a whole body thing, and it's not making sense. Yeah, so those adenophagia and all those crazy ulcers popping up after 14 months on etanercept really throws a wrench in things. We got to rethink everything.
That's a total game changer. The resident now has to factor in these new symptoms, plus the patient's on immunosuppressive therapy. How did their thinking change?
Okay, so first things first, they had to consider opportunistic infections. Etanercept knocks down the immune system, right? Leaves him open to infections that normally wouldn't be a big deal.
Right, you can't just assume because one test for infection is negative, they're all negative.
Exactly. Those initial tests for the usual suspects, like fungi and herpes simplex, those were negative. But the resident knew they couldn't rule out other things. Could be other viruses, bacteria, even some weird fungal infection.
So they had to broaden that infectious workup.
Absolutely. Another thought was drug-induced ulceration. It's rare, but TNF-alpha inhibitors like etanercept can cause those mucocutaneous reactions, including ulcers.
So the treatment itself might be part of the problem.
Right. And then there's a possibility that the etanercept is unmasking something or making something worse that was already there.
Ah, the paradoxical reaction.
Exactly. With his history of those recurrent oral ulcers, the resident was really thinking about Behçet's disease.
Behçet's, that can be a tough one to diagnose.
It can. It's a multi-system inflammatory disorder, right? Can involve the mouth, genitals, skin, joints, eyes, even the nervous system. Genital ulcers are common, but not always there, so we can't rule it out just because he doesn't have them.
And to make it even trickier, Behçet's sometimes hangs out with spondyloarthritis, which could explain the back pain and sacroiliitis.
Plus, there have been cases where TNF-alpha inhibitors have triggered or made Behçet's worse. Fits with our case, right?
Yeah, that's like all signs pointing to Behçet's.
Seems like it, but gotta be careful. Always consider other things.
Of course, of course. What else was on the resident's radar?
They also considered inflammatory bowel disease, specifically Crohn's disease. Crohn's can cause oral and esophageal ulcers. His fecal calprotectin was only a little high, but can't rule it out completely.
Crohn's, famous for those extraintestinal manifestations, definitely worth considering.
And don't forget about the possibility of a paradoxical inflammatory reaction to the etanercept itself, not related to Behçet's or anything else specific. Always got to think about that when you're messing with the immune system.
So the resident had a lot more to think about now. What did the attending recommend at this point?
The attending knew this was urgent. Those ulcers, the adynophagia, needed to be addressed ASAP. They said, get ENT in there right away, laryngoscopy and biopsy.
Makes sense. Got to see what's going on in there, get some tissue.
Yeah, and a full workup of that biopsy tissue. Look for signs of Behçet's, other inflammatory stuff, even malignancy, though that's less likely, viral studies, bacterial and fungal cultures, even direct immunofluorescence, the whole 9 yards.
Leaving no stone unturned.
Exactly. They also wanted to expand the infectious workup with blood tests, CMV and EBV, PCR, bacterial cultures if he started showing signs of systemic infection.
Hitting it from all angles.
For Behçet's, they said, get rheumatology back in there, get a super detailed history, look for any other clues that fit the diagnosis.
Genital ulcers, eye problems, skin lesions, neurological symptoms, vascular stuff, the whole shebang.
Yep. They even mentioned a pathogy test if someone knew how to do it. Not a routine thing, though.
What about the etanercept? Keep going with that.
They said, pause it for now while we figure things out.
Smart move. Don't want to make it worse if it's an infection or a drug reaction.
Right. And while waiting for the biopsy, maybe try some things for symptom relief.
Like topical anesthetics or painkillers, maybe steroids if they're pretty sure it's not an infection.
Exactly. Manage the symptoms while we hunt down the cause.
2 birds, 1 stone.
And this really shows how important it is to have different specialties working together, right? ENT, rheumatology, maybe even infectious disease, all on the case.
Real team effort. Now, as we'll see in the last part of our deep dive, the case takes another crazy turn.
The plot thickens.
So last we left off, they were trying to manage the odynophagia and those ulcers. Behçet's was still a strong contender, but they hadn't ruled out infection.
Yeah, it was like trying to hit a moving target. The diagnosis kept shifting.
Exactly. The biopsy results from the oral ulcer unfortunately didn't make things any clearer. The report came back as non-specific. Inflammation, but nothing that screamed Behçet's or anything else specific.
Non-specific findings, they're a pain, but they happen. Means we got to dig deeper, think about other options.
And they tried treating him, right? Intravenous, cyclover, caspofungin, oral itraconazole. But the symptoms just wouldn't quit. They managed the ulcers with topical glucocorticoids, at least for some relief, and they stopped the etanercept like the attending suggested.
So still no idea what's causing those ulcers, and now the initial treatment isn't working either.
And then Get this, he starts running these high fevers, like 39 degrees Celsius. They do another CT scan of the chest and see that those lung nodules we talked about, well, they've gotten bigger. And one of them even has a small cavitation now.
Cavitation, especially with the persistent inflammation and everything coming back negative for infection so far, that really narrows down the possibilities. Makes you think about atypical mycobacteria, fungi, maybe even a granulomatous disease.
Like the case just keeps throwing curveballs.
It does. So they had to investigate further, focus on these new findings.
What do they do next?
They did a bronchoscopy, got a closer look at those lung nodules, took samples for a more thorough analysis. But again, everything came back negative. Stains and cultures for bacteria, fungus, mycobacteria, all negative.
Another dead end. It's like they were chasing a ghost.
Felt like it sometimes. They also did an EGD, checked out the esophagus, stomach, duodenum, all normal.
So still no explanation for the odynophagia or those stubborn ulcers?
Nope. But then here comes the big twist. They do a CT scan of the abdomen and pelvis and find thickening of the terminal ileal wall plus bilateral erosions in the sacroiliac joints.
Wait, terminal ileal thickening, isn't that like classic Crohn's? Could this be the answer they've been looking for?
It sure seems like it. This changes everything. All those seemingly random symptoms start to make sense.
The aphthous ulcers, the sacroiliitis, the inflammation, the weight loss, all fits with Crohn's. Oh, what about the lung nodules? Could those be related too?
They could. Lung problems aren't unusual in Crohn's. Could be granulomatous inflammation or even organizing pneumonia.
So Crohn's is now at the top of the list.
Yep. And they decided to do a colonoscopy to confirm.
Finally, you're getting somewhere.
Right. But before they could schedule it, the patient gets readmitted with another bout of severe odynophagia. Those ulcers were relentless.
It's like the disease was playing games with them.
It really was. And then, during this hospital stay, things go downhill fast. He suddenly gets this intense abdominal pain on the right side, plus melena, which means there's bleeding somewhere in the upper GI tract.
That's a huge warning sign, especially if it is Crohn's.
Absolutely. They rushed him in for a CT scan of the abdomen and found free air and contrast extravasation, clear signs of a perforated bowel.
Emergency surgery time.
You got it. They did an exploratory laparotomy and found a pinpoint perforation about 15 centimeters from the ileocecal valve. The ileocecal valve and the distal ileum were all thickened and inflamed.
So not only did they confirm Crohn's, but they also found a life-threatening complication.
Crazy turn of events. They did an ileocystectomy, removed the damaged part of the bowel. Luckily, the surgery went well.
And the pathology report confirmed it was Crohn's.
It did. Active and chronic ileitis, all the signs pointed to Crohn's. They didn't see any granulomas in this specific sample, but the overall picture was pretty clear.
What about those lung nodules? Did they ever biopsy those?
They didn't. Considering everything else that was going on, plus the risks of another invasive procedure, they decided against it. They figured the nodules were either organizing pneumonia or necrobiotic nodules, which can both happen with Crohn's.
So sometimes you got to make a judgment call based on the big picture, even if you don't have all the pieces.
Exactly. After the surgery, they started him on adalimumab, another one of those TNF-alpha inhibitors, plus methotrexate and immunosuppressant.
Interesting. After all the trouble with etanercept, why did they go with adalimumab?
Well, even though they're both TNF inhibitors, they work a little differently and have different side effects. Adalimumab just seemed like a safer, more effective choice for this patient.
And how did he do on the new treatment?
He made a fantastic recovery. Within 6 months, his back pain was much better, inflammatory markers back to normal, the bone marrow edema in his spine and sacroiliac joints was gone, and those lung nodules vanished.
Wow, a total 180.
It really is. He was back to exercising, his weight stabilized, basically back to his old self.
What an incredible case. Started with chronic back pain, almost died from a perforated ball, and ended up with a successful treatment and a full recovery. It really shows how important it is to be thorough, to keep digging, and to be ready to change your thinking when new information pops up.
It's a textbook example of how something that looks simple can turn into a real diagnostic puzzle. Highlights the need for a team approach, good clinical judgment, and a healthy dose of skepticism.
Reminds us that we're always learning in medicine. Even the experts can be surprised.
So as you think about this case, think about how you would handled it at each step. What red flags would you have noticed? How would you have adjusted your thinking as you got more information?
Because sometimes the most important diagnosis is the one you miss at first.